All right, we are back with Chapter 9, Part 4. Now, I wanted to show you this picture, and these are actually the villi of the small intestines, and this picture is way better than my drawing. So what we're looking at here, if we were to take the small intestines and take this portion out and blow this portion up, this is what we're looking at. And the wall itself, to the naked eye, is very wavy. And those waves, once again, increase surface area. On the surface itself, we have waves as well. And these waves are called the villi. If we were to take this section of the colon out and look at it, the villi are not visible completely by the naked eye, but if you were to take a little magnifying glass, you could see them with that. And looking at them in this drawing, these villi increase the surface area, and you can actually see there's blood vessels and lymphatics right in the center of them, which help to contribute to that absorption. So people with celiac disease who lose these decrease their surface area that they're able to use for absorption of nutrients in the small intestines. Now, moving on to inflammatory bowel diseases. There are two main ones that we're going to talk about, Crohn's disease and ulcerative colitis. These will cause a chronic inflammation in the GI tract because they are inflammatory disorders. They tend to have periods where they have exacerbations, and then they have periods where it remits and they feel better. There is a genetic association with this that triggers their autoimmune response. Keep in mind that we have normal inflammatory, or I should say normal immune responses along the GI tract that helps to fight infectious agents. We eat bacteria and viruses, we inhale them, they get into our system, and all along the GI tract, especially along the ileum and somewhat along the colon, we have white blood cells that are waiting right there, just underneath the surface, ready to fight infections. With people with inflammatory bowel disease, for some reason, this area has become overreactive, and they start to have autoimmune responses that overstimulates their immune response, which starts to damage the inner lining of the colon and parts of the small intestines. So it's a good thing gone a little awry. The first one that we're going to talk about is Crohn's disease. And this is slow developing that may develop in adolescence. This affects the ileum of the small intestines, which is that last part of the small intestines as it joins into the colon, and it also affects the colon. I've read that it can go all the way up to the mouth, but we're just going to stick with these two to limit it down for you. So Crohn's disease is going to affect the small and the large intestine, specifically the ileum, and it can affect most parts of the colon. Now, it forms fissures, and it has little raised areas and depressions between them, which creates what's known as a cobblestone appearance. And I do have a picture for you. I'll show you in a little bit. But if you don't know what cobblestone is, like cobblestone streets are raised stones that they've placed down next to each other and filled it with some sort of, I don't know what, to create a road. That's what the wall looks like in Crohn's disease. The entire thickness of the tube becomes thick and rigid as well. When that happens, if you could imagine, if this were a normal colon or ileum, if it were to become inflamed from Crohn's disease, that same size tube now has a thicker wall, which will decrease the space of the lumen or the opening through which feces can pass. So if it becomes really inflamed, feces will get trapped, can't get through this opening. It'll absorb more water from it. They get constipation. The inflammation goes down. Feces can now pass through. It can actually move quicker, and they get diarrhea. So that's one of the contributing factors towards this disease. They can also get cramping because they're not passing that that feces and distension of the abdomen as well. Now with ulcerative colitis, rather than thickening that intestinal wall, what happens is it'll cause inflammation, which will erode away at the epithelium, which is the inner lining. You get surface erosions that actually present as ulcers, and it looks like that inner lining or that mucosa has been stripped away. That will actually create the inability to absorb things along the colon, and this ulcerative colitis disease only affects the colon, doesn't affect the small intestine. So in the colon, you'll get destroyed mucosa, so they get decreased absorption, feces moves through quicker, it maintains water in it, and they get frequent periods of diarrhea, as many as 20 times daily. And they can also get blood and mucus in there because you've damaged the inner lining of the colon. They can actually bleed into the colon and secrete more mucus because the body's trying to protect itself in a response to that damaged inner lining of the colon. Question time. So after a colonoscopy, a patient is told they have a cobblestone appearance of their large intestines. They will most likely have A, ulcerative colitis, B, Crohn's disease, C, inflammatory bowel disease, D, two of the above. Answer that question, and then we're going to move on to irritable bowel. Okay, so if you remember, ulcerative colitis and Crohn's are both inflammatory. This is not inflammatory. This is irritated bowel. This is associated with exacerbations that are usually associated with stress. So there's some psychosomatic issues with irritable bowel. So they'll have, excuse me, alterations in bowel patterns as well, diarrhea, intermittent constipation. So this is less serious than inflammatory bowel disease. It's not inflammatory, and it doesn't cause permanent damage to the intestines. It can lead to nutritional deficits and hemorrhoids. Usually it'll happen due to stress or anxiety, food intake, hormonal changes. You get those typical presentations of abdominal distress, distension, fullness, bloating, fleshless, right? Okay, a little farting there. And intermittent pain as well. So the pain is exacerbated by eating and relieved by excretion or defecation. And we spoke about that intermittent constipation, diarrhea. And there can be also, just as a little side note, intense urgency to go to the bathroom with people with irritable bowel if they have to take a poop, for lack of better words. Okay, so it creates that urgency where they have to go immediately. Diverticular disease, which leads to diverticulosis, which is the condition, and diverticulitis is if you get an inflammation in it. Diverticula are outpocketings of the intestines, usually sigmoid or descending. It can go, I think, further up than that. And these pouches in the intestinal wall happen because there's been some sort of weakness that has broken through that intestinal wall, or it could be from excessive pushing when you're trying to defecate, and it puts stress on that. It could be due to extremely difficult childbirth because you have to bear down as if you're trying to create a bowel movement. So a lot of things can happen that can aggravate that layer of the colon and push out, creating diverticula. People can be born with it. I think quite often it is acquired due to excessive straining to create a bowel movement. Low fiber diet can also contribute to this, especially once you have the diverticula. One of the theories is that constipation will keep feces in the colon longer, and it will actually deposit into those outpocketings, which will then cause inflammation because it's stuck in there. Diverticulosis is the condition of having diverticular disease. Usually this is asymptomatic. Diverticulosis denotes that it's asymptomatic. You can have one, you can have multiple. If those diverticula become inflamed, you get diverticulitis. It's usually because fecal matter gets stuck in there. So it's nasty disease. I've actually had this. I was hospitalized almost for a week with it. And the issue with people with diverticulitis is you can perforate your bowels, and then the feces can go into the abdomen, leading to peritonitis, hemorrhage. If you lose enough blood, it can lead to shock. So you have to give complete bowel rest to that patient until the inflammation goes down. And I was on heavy-duty antibiotics for quite some time until it healed up. Thank goodness for all you lovely nurses that took care of me when I was in there. So manifestations, abdominal cramping, you can pass a large amount of blood if one of the diverticular rupture, low-grade fever, abdominal tenderness. Usually it'll be in the left lower quadrant because that's where the sigmoid and the descending colon are. Abdominal distension and constipation really should add in there with intermittent diarrhea. I think when the swelling goes up and down, you get that intermittent constipation alternated with diarrhea. So let's practice a few here. This is a little tough. Out of these inflammatory things, what do you think this fella might be? And remember the anatomical descriptions that I've given you today. If you need to pause, go ahead and do so. Otherwise, we're going to take a peek. That is appendicitis. And I told you it was about the size of a pinky, and this one is pretty expanded. Luckily, or hopefully they got it before it broke open. What do you think this might be? Obviously, we have normal on the left, damaged on the right. Think back to the pictures that I've shown you microscopically or up close. This is definitely going to be celiac disease and the loss of those villi. As a sidebar, once they stop eating gluten, those villi can rebuild themselves. And I think this just says celiac disease as well. What do you think these might be? And once again, if you have to pause the tape, do so. If you look close to the upper left-hand corner, out of everything, those are some pretty cool x-rays over here as well. So this is a full colon here. Well, not a full length of the colon, I'm saying, as opposed to this one has been cut open. Oh, now you're like, I got it now. Here's an up-close picture right there. These are all diverticula. And I like this x-ray right where they did a barium. And you could see the outpocketing of the diverticula. That's pretty neat. So, diverticular disease. Okay, and there are descriptions there if you want to go over them. What do you think this is? This is back a little bit. If you take a minute and look, you could also pause the tape. This is peritonitis, an inflamed digestive system. Redness and swelling in the small intestines. All right, looking at this one, the left and right are two different diseases. They're both disease processes. We're looking inside of the lumen of the small intestines and or colon, probably most likely colon, on the left. And if you need to pause the tape, go right ahead. Otherwise, we're going to take a look. That's Crohn's disease. Yeah, there's that cobblestoning. You could see the little round elevations, just as if they were stones in a cobbled street. And on the right, you can see the redness in the lower part of that colon. There, the red streaks. This is going to be ulcerative colitis. Tricking you a little bit here. We've actually already looked at this. What do you think this might be out of what we've spoken about? You could see distension, ding, 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 of the abdomen, all the excess fluid, possibly air that might be in there. It's most likely fluid that's showing up there. This is going to be peritonitis that's causing swelling and distension, especially to the right side of that patient. All right, I should have done this in the beginning. I apologize, but I think this is going to be more applicable as we move into the next few cancers. I want to do just a quick cell review, and I'm going to keep it really simple. There's a multitude of cells that line all the surfaces of the body, and these are a list pretty much of all of them. This may look a little familiar. This is in the respiratory tract. Pseudostratified, ciliated, columnar there. But what I want to point out to you in the GI tract is simple columnar and stratified squamous. So simple columnar begins in the stomach and goes all the way to the rectum. And we have this simple columnar, so we have a thin membrane. It's not really a membrane, I'm just saying it, through which we can absorb substances and or secrete substances. So simple columnar from stomach all the way down to rectum. Stratified squamous, you could see, is multiple cells. Each one of these purple dots is a nucleus. And stratified squamous is going to be in the mouth and the esophagus and the anus, which are areas of higher friction because we're ingesting substances and excreting them. So we create more of a protective layer with multiple cells stacked on top of themselves. And the only reason I bring that up is because in oral cancer and esophageal cancer, the stratified squamous cells are going to be the ones that become cancerous. Okay, in esophageal cancer, what'll happen is the esophagus has stratified squamous, but what happens is in esophageal cancer, the bottom of the esophagus actually changes and the cells turn into this simple columnar, which makes it more prone to cancer. Okay, so I don't want to get too crazy, but I felt like I needed to do a little bit of a review there. So oral cancer is usually from squamous cells. It's from your typical things that you would think would cause cancer in the mouth. Smoke, that smokeless tobacco that you stick in your cheek, excessive alcohol consumption, and HPV infections. Very treatable if you find it. It shows up as possibly just a little white spot that has abnormal edges. It could also look like an ulcer. It could be a nodule, and it shows signs of cancer such as easily bleeding, and it doesn't heal. If we see esophageal cancer, it's going to be pretty commonly from the GERD causing acidity into the lower part of the esophagus, changing the lining of the esophagus into that simple columnar. Okay, it's that chronic irritation that they're talking about. So what that can lead to, if you can imagine the esophagus as a tube entering the stomach, it can cause a stricture or a thickening of the esophagus that actually will tighten down the opening until it's almost closed off. And you can also have tumors which will grow into the opening of the esophagus, also creating an obstruction, which we had spoken about previously, those obstructions. So you could have a respiratory compromise in addition to those obstructions, and also esophageal bleeding leading to blood and vomit. Usually asymptomatic early. That's why these tumors grow big enough to block off the esophagus. You know, hopefully you catch it early and can help that patient. They would also have pain with swallowing, possibly some chest pain. You know, your typical sign of weight loss with people who have cancer and hematemesis. I think I say it right the first time, then I always think I say it wrong for some reason. There's certain words that I just get stuck on. The vomiting of the blood with the coffee ground appearance that we spoke about previously as well. So gastric cancer. This can be from H. pylori. This can also be from certain preserved foods, such as the nitrates and the nitrites that are in hot dogs, or, you know, some of the sausage that you can get, there's a strong link with that. That's why you're seeing a lot of those cured meats saying that they're preserved without nitrates and nitrites. Usually it can occur in several forms, but adenocarcinoma is the most frequent type. Don't worry about that. I'm not going to get too much into that. It's just a glandular form of the gastric cancer. I want you to know more of the signs and symptoms and what it can be caused by. So abdominal pain, swelling, and fullness, epigastric discomfort. If you could feel a mass, that would obviously be pretty obvious. And the dark stools, once again, because with the gastric cancer you could get erosions that could cause bleeding, which would then go into the feces and make it darker. Liver cancer is just a devastating disease because, of course, if it spreads far enough and destroys the liver, it can affect all sorts of metabolic functions. Quite often this is going to be a secondary tumor from breast, lung, or possibly GI cancers. You can get this as a primary cancer from chronic cirrhosis and or hepatitis. So manifestations similar to other liver diseases, your jaundice, anorexia, nausea, vomiting, enlarged liver, enlarged spleen, portal hypertension, abdominal swelling with ascites, and your typical sign with cancer of weight loss. I just want to make a side note that with the liver, you can also get little hemangiomas in the liver, which quite often can be mistaken as liver cancer. And I'm only sharing that with you because my mother was diagnosed with liver cancer, and guess what? It was a hemangioma, and it just devastated her for a week because she had to wait that long to hear back. So as a side note, a hemangioma is dilated blood vessels that can actually grow in a bunch in the liver. So just a little nugget of knowledge. Hopefully the experience with my mom can give you a little bit of information just to look out for your patients, a little bit better. So let's do a little practice here. What do you think this is? It's labeled. Once again, Dr. DeShava messed up. But I thought this was pretty cool. This is going to be gastric cancer. And I always say that, and then I feel bad because it is a cancer. This is a cool x-ray. You could see that gastric cancer has caused a blockage that is not allowing food to go through the pyloric region and get into the duodenum. And that's showing that with this contrast medium for this patient. This picture is probably pretty easy, but you're going to have to identify the organ to know which cancer this would be. You can see the normal tissue, which is on the periphery, and in the center you could see abnormal tissue, which is actually starting to take on a greenish appearance like bile that we see in the gallbladder, which is interesting. So the bile is probably collecting in this, and I just gave it away, liver cancer, and not getting pushed out because those cells or those hepatocytes are not working properly. Take a look at this and you can see the whitish appearance that's on the tongue. And once again, that'll be on a stratified squamous, damaging those cells. And because there's two of them and they're starting to get an abnormal boundary, that would be a good sign of, you got it, oral cancer. This one you might need to take a second to get oriented here. If you take a look at this, they're giving them a contrast medium and taking a good x-ray, and you could see as it narrows at the bottom, try to think of what this is and what's happening. And once again, it's happening at the bottom, right where the esophageal cancer is causing a narrowing of the opening of the esophagus. So now the barium can't get through it and down into the stomach very easily. It gets narrowed. So there's that narrowing that happens when the esophagus swells and you get the strictures and the dilated blood vessels and the tumors pushing in and creating a narrower opening through which that barium will pass. I thought that was a pretty cool picture. Okay, so pancreatic cancer is devastating. Oh, God, it's just devastating. It's very aggressive. And it is aggressive because what happens is the cancer in the pancreas opens up all those acinar cells, and the acinar cells have the digestive enzymes. Once those are open, the digestive enzymes get activated and they start to eat the tissue around it, which allows the cancer to spread even more. And then the cancer can get out easier of the pancreas and spread in the bloodstream and can metastasize. It's just a nasty, nasty cancer. Once again, don't worry about adenocarcinoma because we didn't really get into the definitions. Once again, adeno does mean glandular if you're interested, and it's just starting in the glands of the pancreas is what that means. Often asymptomatic until it's well advanced. Once again, you know, that's bad for cancers because it gives it more time to spread. So upper abdominal pain, and it does go across the abdomen. So most likely it would be more of an epigastric pain that can radiate to the back. People could present with being jaundice, dark urine, clay-colored stools because they're not absorbing nutrients and things are going straight through. You're also going to have a buildup of bile in your system, malnutrition because they're not absorbing things that they would if they were normally using the proper enzymes to break foodstuffs down. Colorectal cancer has had a lot of awareness in the past, 15, 20 years, because once again, this can progress without many signs and symptoms until it is in a more aggressive state. And so colonoscopies have become a great thing for people to get to prevent it, because quite often what will happen is people will develop polyps in the colon, and those can become cancerous. So they will remove them and prevent that from happening. So there's a strong familial history with this. Obviously, as we get older, we get tissues breaking down quicker. Obesity and increased fat causes a lot of inflammatory issues which can progress cancers. Tobacco use, we know, promotes cancers as well, and inflammatory bowel diseases can also contribute towards colorectal cancer. So once again, I mentioned this is often asymptomatic until it's well advanced. So it can manifest as lower abdominal pain and blood in the stool, occult being dark tarry stools, or frank being blood that you can see, red blood. So I did put some screening in here because I think these are important. So fecal occult blood tests you can do yourself at home now. You could have the flexible sigmoidoscopy every 5 years, or a full colonoscopy for people who have higher risks actually can be done every 3 to 5 years if they have a familiar history of it. Prevention is just so key. All right, question time, and then we are done with gastrointestinal. Pancreatic cancer is usually aggressive because it is a peritoneal organ. I made a little bit harder of a question this time. It is an organ that is not often physiologically active. It releases enzymes that destroy the surrounding tissue and allow cancer to spread. D, the pancreas releases digestive enzymes directly into the blood, which would make the most sense. Thank you very much. As always, if you have any questions, feel free to reach out, and I hope you have a great day.